This House believes that clinical research offers better value than laboratory research when it comes to improving patient treatment. There's the motion today. I'm going to show you beyond all doubt that you must support it. Ian and I spend a lot of time trying to convince surgeons that we've got to keep moving forward. Research is anything that generates new information. And it's actually not possible to stand still. If you try to stand still, everyone else goes past and you fall behind. And in this country, we're actually very forward thinking about how we run and organise our surgical research to improve outcomes for patients. So anything that generates new knowledge, but in particular we're talking about clinical research, and it's extremely tangible how quickly and how immediately we can improve outcomes. And you've heard lots about patients like this today. So the man on the top left is a patient of mine. For balance, I'll show some lovely patients of mine, Ian. He has Parkinsonism and had an angle grinder, and maybe he shouldn't have used his angle grinder, and that bisected his face. The two people in the middle at the top have facial disproportion to the point where it's badly affecting their quality of life and ability to progress. The wee chap on the right clearly has a cleft lip. On the bottom we've got Ian, who had an osteosarcoma in his midface. And at this point I always remember to thank all of these patients who've given me express permission and written permission to speak about them when I'm talking at things like this. The boy in the middle has been relentlessly bullied at school because of his nose, and the lady in the bottom right is having a facelift. And this is all about the people we've heard so much about today. And when you look at these people, there's only one on this slide who hasn't had their whole face divided apart to allow us to remove a tumour and reconstruct and put back together for function and rehabilitated with implants planned ahead. Only one hasn't had that, and we're quite good at that. And they're the ones that are living with the side effects of disease and have survived it. But bear in mind that if we pull out head and neck cancer in general, still less than half of the people survive, and they're not on my slide. We have to improve. And this is about surgery, and so a few slides. This is me looking particularly handsome in the operating room. And this is me with a colleague, because we always work in teams. So it's sort of a funny era that we're in where complications and things come down to a single surgeon, but this is all about teams, and research is all about all of us, and it's all about NFORC. And here's a few things about surgery. We can't just stand still with that. 85% of us or more will have an operation of some description in your lifetime. And the average number of operations of having been experienced by a person who dies in the UK now is 4.5. So we've clearly got to move all that on. But that's quite tricky, and I'll explain why. Here's our surgical team. Obtaining functional reconstruction. It takes us all day to do this. All day to do this. Curing cancer is a good aim, and it might be just controlling cancer. Either way, we can definitely control it. And with all the molecular complexity that Ian's expertly touched on, and which fascinates me, and my PhD is in the lab actually, it turns out that Ian's option of, if you can remove it, that's a very good thing, because it's so like the normal stuff just gone wrong. If we can remove it safely and effectively, it's very, very effective. So if it takes the whole team of us there, in that slide there are 4 surgeons and a scrub nurse, and that's only part of the team, how are we going to get people to do research as well? Well, it boils down to equipoise. And I always ask trainees, and you have to know this before you get to be a higher surgical trainee now in the UK, equipoise is present if there's no absolute evidence that one thing is better than another. So if you consider some of the things that you've seen that we as a group do to people today, you realise this, that you have to be absolutely certain you are doing the right thing before you start and embark on an operation like that for a patient for the best reasons. And this is a difficulty for surgeons like Ian and me and David to convince our colleagues that we might try something new. So what we say is that it's the most confident of the surgeons that can challenge the status quo, challenge the dogma, challenge the gold standard with some new information to move forward. Now this is all about value, and value is the regard that we hold the results of something in. So the value of clinical research. Can we deliver clinical research? Here's a lovely paper from BMJ Open on which Ian's an author, talking about how difficult it is to get surgeons to recruit patients into trials. Now, interestingly, they didn't ask me to be part of that paper because I got on fine. And there's lots of trial design lessons that we learned trying to recruit to this. But what that graph shows you is that 419 people, like the patients we've heard from today, are very happy to take part in a study where half get one thing and half get another to see which is best. And sometimes people say to me, well, they just didn't really understand it, they just want to please you because you're the doctor. But this couldn't be simpler, this trial. We either applied a stain to show us where the precancer cells were, or we didn't. And patients quite often would say, so will this help me, doctor? And the answer to that is, well, I don't know. And then they say, well, will it help somebody else? It will definitely help someone else, because this either helps or it doesn't help. Let's look at a few examples of clinical research from history then. This is Ignaz Semmelweis. Lots of you will have heard of him. He is Hungarian, of German extraction, was working in Austria, and he realised that the 1 in 10 to 1 in 3 mums who were dying after they had a baby were mostly on the side of the ward where the medical students delivered the babies, not where the midwives delivered the babies. He then spotted that the medical students were coming straight from the cadaver labs where they learn anatomy on dead bodies and coming back out and delivering babies, and the mums were dying. And he said, right, that's it, you have to wash your hands. And when he made them all wash their hands in chlorinated lime, admittedly, the mortality dropped to 1%. But nobody believed him, because Louis Pasteur hadn't described germs yet, and Lord Lister hadn't in Glasgow Royal Infirmary described antisepsis, and McCaul in Glasgow Royal Infirmary hadn't described asepsis, and nobody knew why. And this had a very bad effect on Ignaz's mental health, and eventually he was committed to asylum only at the age of 47, and 2 weeks later he was dead because the guards beat him up. This is a symbol that's familiar to a lot of people, isn't it? The Cochrane collaboration, and it's actually a forest plot. And the forest plot means that people have successfully done a lot of studies, and they all lie towards the left of the line. The line in the middle means there's no benefit and there's no harm. And overall, if you put all these studies together, there's benefit. Now, I hear you ask, what clinical question does this answer? When a baby is born at earlier than 32 weeks of gestation, its lungs don't produce surfactant. They get respiratory distress to the newborn, and some of them die. The Cochrane collaboration assessment of all of that clinical research proved that giving steroids to the mum for 24 hours before the baby was born stopped all that. There are millions of people alive today because of the power of clinical research in proving that that was a benefit. And some of the people in this room were probably born early enough to have benefited from that clear knowledge. Let's come back to the NFORC field now. This lady's got a cancer on her tongue and it's in the middle. About a third of the time, we leave behind some precancer cells that we heard about today. So how do we know where to get this right? If we get a 5mm clearance in this cancer, survival is really good. For every millimetre less than 5, we lose about 8% of our patients. It's really important to get that right. At the moment, we can only do it by looking and feeling where the cancer is. The big trial that I showed you that my patients, half got the stain, half didn't, volunteered to take part in, had this stain applied or not. And this showed in this lady a big patch of precancer that we might have left behind, and that's why her disease would fail. Here's another good example. A man sent to my clinic with a kind of sore tongue and it looks a bit funny, is almost what the referral said in lay terms. We didn't like the look of this, and he didn't smoke or drink. So we did a biopsy. Well, what's tricky about this is that all this bit looks a bit funny. So which bit do you choose? Now, the exam answer for a surgeon is the worst bit. So what's the worst bit? Well, we usually go for a bit that's white and red and hope for the best. But then the expert pathology team tell us this is moderate to severe dysplasia. Now, the actual grade of dysplasia doesn't absolutely determine cancer risk, but there's a risk, and it generally correlates across the board. And especially since I can't make this man stop smoking because he doesn't, and I can't make him stop drinking because he doesn't do that either. We don't know why he's got it, and we'd like to remove it if we can. So another trial coming up is we apply that stain again, and this absolutely personalises his treatment, because we can take away all the stuff that's the trouble and leave behind all the stuff that's normal. So we maximise his function afterwards, we maximise the diagnostic yield, and we don't leave the stuff behind that turns into a tumour. And we avoid an awful lot of the stuff that you've heard about from patients who endure the side effects and complications of treatment. So let's go back to all of these people now and think about the power of clinical research. Ian. The man on the top left was a hoot actually. He came back to my clinic, and there he is, top left. 10 days later, took us 2 hours to put him back together. Very nice result. I said, George, how are you? And he said quietly, well, they've taken away my angle grinder.
Say that again?
They've taken away my angle grinder. Very good. So the two in the middle really changed. Look at that handsome baby boy with his cleft lip, all fixed. There are other sequelae for him though. Ian in the bottom left, 2 years after his treatment, got brain metastasis recurrence of his sarcoma. We need a better answer for Ian. The boy in the middle had a better life, and the lady in the bottom right was very happy. Ladies and gentlemen, we've talked all afternoon in a very relentless, busy afternoon in a wonderful, full auditorium, which is a bit quieter now, with lots of people eminent in clinical research, lots of professors, Kumar, Hutchison, and Snape, if you noticed earlier on, and it's been great fun. Ian, thank you for asking me. Ladies and gentlemen, if we are going to vote, you have to vote for this. Thank you very much.
Okay, I'd like to thank Jim for his talk. I think everything he presented was excellent. I think it was good, and I think it was largely true, apart from his statements concerning what we should do about the vote for the motion. I sort of agree. I mean, lots of things have happened today where we are overlapping with various people in various ways. But when I looked at this thing that Ian had said, I thought it was pretty daft, really, but that was just me being silly, I expect. Because this House believes that clinical research offers better value than laboratory research. I wondered what value meant. And value is funny, and people talk about value in different ways. It means different things. I mean, Oscar Wilde wrote, I think, that a cynic is a man who knows the price of everything and the value of nothing. And I think that may apply to a few politicians, but I don't think it applies to researchers, either basic or clinical. And I think we actually probably hold similar values. I started off as a surgeon, so I got a little bit in common with Jim, and he's got a little bit in common with me because he's done a PhD in some basic research, so we sort of overlap a bit ourselves too. But it seems to me that both basic surgeons, basic researchers and clinical people have the same values. We want to ameliorate disease, we want to cure disease, we want our patients to live longer, we want our patients to live happier, we want them to be more functional, and we all agree on this. So if we all agree on this, where do we differ? Well, it seems to me that the big difference that we have between us is the matter of time. The surgeon has to treat the patient today with what is available today. It's right there in front of him. If it isn't available, he can't use it. He can't wait till next year when they've got a new drug, or the year after, because he has to treat his patient now. The laboratory researcher has a little more flexibility, or at least he should have a little bit more flexibility, so he can wait. He's looking to save something in the future, and he's hoping to improve treatment by developing new drugs or new techniques or new equipment which allows the patients of the future to survive. And often, I think, would be something that would be on my side a bit, I think if the researcher discovers something of that sort, it often applies to lots of patients, whereas the surgeon is only dealing at this moment with the patient on the table. So given that difference, it really means that clinicians going about the primary business deliver patients now, the researchers are looking to the future. But both are valuable aims. They're complementary, and I think many people today have talked about the need for collaboration. If it is a matter of timing, then the laboratory advantage is not going to be in the clinic until a long time after tomorrow. And so I think we have to look at this historically, and it's interesting because I mean several things today that I was going to talk about in my talk have been used in the opposite direction. It depends how you look at yours was there too. I would look at sterility as being one of the major things that have improved surgery. Without sterility, most of our patients would die. I think we just wouldn't get there. How did that happen? Admittedly, there are some people there, but I would suggest that it starts with Pasteur and germ theory. And Pasteur's germ theory started in the laboratory trying to stop things fermenting or make them ferment. It then later spread out the consequence of this conclusion. If you go into any hospital, the whole walls are plastered with wash your hands, okay? This is saving lives. This really comes from the laboratory observation that bacteria exist and bacteria are dangerous. But that was a laboratory observation. What happens if our sterility fails and our patients get infected? Well, we turn to antibiotics. The classical antibiotic is penicillin. Was penicillin a clinical invention? Absolutely not. Fleming was fooling around with bacteria in the laboratory, and he found a fungus in his dish, and being a wise man, he didn't throw it away. Most other antibiotics have come in that way. They've not come clinically. They've come from looking at fungi, bacteria, and other bits and pieces. Heard a lot today about organ transplantation. Organ transplantation, what does it depend on? It depends on knowing about tissue compatibility, histocompatibility. How did that happen? It comes from Medawar. Medawar's work, he got a Nobel Prize for it, was done in the laboratory with animals. Later, it was extended to the clinic. If your histocompatibility is wrong and you fail in that, what do? You turn to immunosuppression. What do you use for immunosuppression? Cyclosporine. How was cyclosporine found? Cyclosporine was found by people looking at fungal metabolism, nothing at all to do with clinical activity. Imaging. How would your surgeon survive, diagnose, or be able to do the wonderful things you do without imaging? Röntgen invented X-ray. He had no interest whatsoever in patients. It was something that was there, hung around. What about MRI? Where did that come from? Well, I believe this was discovered in 1938. It was a standard piece of laboratory equipment for 20, 30 years before it came into clinical use. And then, of course, you get the absolute killer, which is my area, which is stem cell science. Okay, this is an entirely laboratory thing, and in fact, it's not really been into the clinic yet. It's going there. We heard a little bit about that today. But that was a laboratory. Animals. Martin Evans in Cardiff invented that, really. Then it was expressed in Thompson in Wisconsin, and then we go forward. But now we've got this wonderful idea of induced pluripotency stem cells. I can take a piece of anybody's skin here and make an embryonic type stem cell from that piece of skin to make your organs for you. You will not need immunosuppression, so it's going to be much more effective. So I won't talk about that anymore. So basically, all I've really got to say is that I think if you look at historically what's happening, the things that we use now clinically and that we will use in the future clinically to cure and provide value to our patients have arisen through a collaboration. There's been a basic science observation which has been carried into the clinic by clinical research. I think that is going to continue. Translational research, I think, is really where it's at the moment, and translational research relies on the basic scientists, the laboratory people, finding something to translate, but it depends entirely on clinical people being able to translate it. If one or other pieces of the equation are missing, the whole exploitation thing just simply collapses. So I'm going to finish with a story, I think. When I was a student, we used to say, what's the difference between a surgeon, a physician, and a pathologist? And medical know this story. The answer is that a surgeon does a lot, but doesn't think too much. A physician thinks a lot, but doesn't do too much. But the pathologist thinks a lot and does a lot, but only when the patient's dead. Now, I would suggest that the laboratory researcher is a little bit like the latter, because we think a lot, we do a lot, but the fruits of our labor don't enter the clinic for several years, and they need a clinician to intervene between us and the clinic in order to get it there. So I would invite you to vote against the motion on the grounds that it's divisive. It sets the laboratory researcher against the clinical researcher, and we don't want that. So what should we do? Well, I think you should do what I think I'm going to do. As soon as you've voted against the motion, and we've heard from Ian here, I'm going to go to the bar. I'm going to buy Jim a beer. We're going to put our heads together. We're going to work out how we can collaborate for the value of future patient research. Thank you.
Who votes in favour of clinical research? Who votes in favour of laboratory research? Looks about even to me. Which, in fact, is Ian MacKenzie stealing my thunder, and we're not going to the bar, we're going somewhere else.
Oh, okay.
Yeah. It is actually about translational research. It's about the collaboration between patients and surgeons, and between patients, surgeons, and basic scientists. We can give information to them, they can give information to us, and it's all about making us all better, because of course we are not patients, we are human beings. Human beings who happen to be surgeons one minute, patients the next, patients who happen to be patients 1 minute. Are they surgeons the next? Maybe at home. Maybe at home. Thank you very much indeed for coming.